Hello everyone, thank you for joining Family Caregiver Alliance for today's webinar on managing dementia-related behavioral issues with medications, pros and cons, presented by Ron Finley. This webinar is open to caregivers and professionals. CEUs are available through the Board of Behavioral Sciences. In order to obtain your continuing education credit, please email adugay@caregiver.org with your name and license number or other ID number. I am AJ Dugay, the Education Coordinator for Family Caregiver Alliance. Let me give you a little background on our organization. For over 35 years, we have been working through the Bay Area and across the nation to improve the well-being of family caregivers that are providing long-term care. We offer support through educational classes, workshops, fact sheets, retreats, caregiver support services, research, caregiver advocacy, and more. For more information, you can visit us at www.caregiver.org. For the duration of this presentation, your phones will be muted. If you have any questions, you may ask them throughout by going to the GoToMeeting question box on your screen. These questions will be answered at the end of the presentation. Ron Finley won't be able to evaluate drug therapy questions related to a specific patient because that would require their medical background. Mr. Finley will be able to answer more general questions, so we encourage you to send those throughout his talk. After the completion of this webinar, you will be sent an email with a survey. Your feedback is very important to us in shaping our future educational programs, so we would like to thank you in advance for filling those out. Today's speaker is Ron Finley. He has served as a clinical pharmacist with the UCSF Memory and Aging Center. Ron is also a consultant pharmacist at CPMC's Brain Health Center. Without further ado, I'll now turn things over to Ron.
Thank you very much, AJ. My thanks to you and Terry for your assistance for putting this program together, and it's fun for me to continue my long-term relationship with the Family Caregiver Alliance. We have a few educational objectives. I think we'll cover all of these in the next 45 minutes or so. We're going to define what cholinesterase inhibitors are and their management of behavioral issues in Alzheimer's disease. We'll talk a little bit about antipsychotic drug therapy, antidepressants, mood stabilizers, and benzodiazepines. Those are your Valium-like drugs, and what role they have, and some roles they may not have in the management of psychiatric behavioral issues related to dementia. And we'll look at a couple of differences between the types of dementia and the approaches to treating behavioral issues. Little disclosures here, proof in advertising. Many years an RX consultant, a National Drug Therapy newsletter. I'm an associate editor. I work with two private healthcare groups, HGA Healthcare Consultants and Elder Care Healthcare Specialists. And I'm a consultant pharmacist for a project we're doing with the City of San Francisco Adult Health in monitoring medications for adults that are primarily homebound, but not only homebound patients, called the Medication Management Program. So let's look at some of the issues that are very important to consider before we even begin to think about a medication for a behavioral problem. Let's look at what type of dementia this individual has. Now, working in dementia clinics, I've been at UCSF for probably about 30 years in neurology, more recently in the last couple years at the Sutter Health Brain Health Center. So I've sat in on many case conferences and evaluations of patients, and I realized that this is not always an easy task, even among those individuals that are really quite experienced at doing it. But knowing or having an idea at least of the type of dementia, and dementia itself is a collection of symptoms. It's a syndrome. So the diagnosis of dementia in the chart, to me, doesn't give me that much information. Now, we know that probably 50 to 65% of dementias are the Alzheimer's type, so that helps to sort things out a bit. But then there's vascular multi-infarct dementia, frontal temporal lobe dementia, Pick's disease is a component of that area, Lewy body dementia, progressive supranuclear palsy, and some other types of dementias that only in the last few years have been identified. And of course, dementia related to Parkinson's disease and sometimes an HIV disease. Creutzfeldt-Jakob disease is one you probably haven't heard of. That's a prion disease and is in the same class as so-called mad cow disease. So various types of dementia, if you will give us, at least me, some indication of what type of behavioral issues that might occur, and also perhaps maybe the appropriate medication, if a medication is warranted. So that's one of the first places to start, is the type of dementia. So again, starting with the very basic issues, we need a complete medication history. So if you're a caregiver, this is so important that your medical practitioners, nurse practitioners, physicians, pharmacists are aware of all the medications that you or your loved one happens to be taking. And individuals think of prescription drugs, those are usually right up front, but also non-prescription drugs are very important. And some of these, like ibuprofen, Motrin is a generic name, not too many years ago actually were prescription drugs, but aspirin, sleep medications especially, which often contain antihistamines that can impair memory and cognition. We'll talk about that in a few minutes. And an area that sometimes gets left out is nutritional supplements or alternative treatments, including vitamins, herbals, minerals, and so on. And in fact, it's important to think of many of these as medications. Vitamins you may think are generally safe, and they are, but in excessive doses, for example, vitamin B6 in high doses, usually above 300 milligrams per day, can cause some neurological disorders, peripheral neuropathies. Herbals can be real drugs. In fact, some of our very important drugs that we have in medicine have come from herbals. Digoxin, for example, the yew tree has provided us with a cancer treatment, and so on down the line. Galantamine, Razidine, originally came from the daffodil family. So there are, quote, real drugs and herbal products, and that's important to keep in mind. Social drugs, of course, we want to know and need to know about alcohol, nicotine, and caffeine use, and if any other social drugs are being used, such as marijuana. Immunizations are important, including a general medication history. Allergies, drugs or foods are important to know. And it's important to identify, and we can help do that sometimes, if this was truly a drug allergy or an adverse reaction to a drug. For example, if you have an upset stomach with aspirin, that's not a drug allergy. If you break out in a rash, that very often can be a drug allergy. So knowing what worked and what doesn't work is helpful, especially regarding pain medications, and I'll come back to that, because pain is often a component, underlying component of a behavioral condition, behavioral problem. And again, medication adherence. We really need to know which medications are really being taken and which are skipped sometimes. And we know that that's not uncommon. But it's important at this point that we know all the medications that are being consumed on a daily basis. So this is part of the basic foundation of beginning to think about, if we're adding a drug, we need to know what drugs are there currently, so we can avoid some potential problems of drug-drug interactions or adverse drug reactions. So drugs and cognitive impairment. They're a fairly common cause and reversible in most or almost all cases. And impaired patients are particularly prone to delirium from some drugs. So these, in individuals that have Alzheimer's and Lewy body type dementia, in particular LBD or Lewy body type dementia, are the anticholinergic drugs. Sometimes drugs that are very sedating, and again, that's the Valium-like drugs or narcotics, a number of others, some antihistamines. They can actually cause a delirium. We see this more commonly in the hospital setting, so it's important that pain be treated appropriately, but sometimes excessive amounts of pain medications that are sedating can lead to a cognitive problem. So benzodiazepines, the Valium-like drugs, and alcohol are always some of my key drugs that I'm looking for. So these drugs, Valium and Ativan, that's in that same family. I'll come back to that in a few minutes. these are medications that actually can cause memory impairment. In addition, concern always in older adults and younger adults too, for that matter, as these medications can alter psychomotor skills. In other words, they impair coordination, and often without the clue of feeling drowsy. So you may feel like you're fine, or when you question someone, they say, yeah, I don't feel drowsy at all, but their coordination skills are still impaired. So the anti-drugs, the ones we're looking for, cholinergic or atropine-like drugs that have that same characteristic, and they're common offenders. And what I tell my newer medical residents and fellows sometimes is, and sometimes my physicians I work with as a reminder, that it's important to add up all of the central nervous system depressants, all of those medications that can cause sedation, that can impair cognition, and add up all of the anticholinergic, the atropine-like drugs that your patients are taking. And very often it's a combination. I just saw a patient, I reviewed a chart yesterday, where each individual drug probably wasn't the problem, but collectively about a half a dozen medications are contributing to this gentleman's cognitive impairment and possibly hallucinations. So when I look at this, I'm sort of making a decision to go through and pick out factors that may precipitate a problem, even before we get to talking about treating a behavioral issue. An important, I think, area as you pick up a prescription, and let me encourage you at this time to use your community pharmacist to ask some of these questions that I've presented or some of these issues that I've brought up. I've been teaching at the University of California. I'm retired now, School of Pharmacy, probably for over 32 years, actually. Retired from that position, kept my appointment in neurology, and I still teach. But it's important to use your pharmacist as a resource, and they are available. So this slide in this little cartoon is to remind you that when you get a new prescription filled, you'll get a sheet package information sheet of possible side effects of that medication and some general information, often on how to store it. Some of the side effects would only occur, that are listed there, would only occur if you took an excessive amount. Rather than just take it home and read it, and sometimes becomes alarmed if you see something that says may cause heart irregular beats or something like that, is ask the pharmacist to circle the ones that are most likely to occur so you really know what to look out for. So I say that because I sometimes have found that individuals get prescriptions filled and don't take it or don't give it to their family member or loved one because they're concerned of the side effects. And ask your pharmacist to clarify any issues in that little published sheet that you don't understand. So I sometimes find, and I see information from my patients that come from pharmacies, and sometimes it's 2 or 3 or 4 sheets of information, which is a lot to go through. So having said that, let's now get to some medications that we could consider as medications that would be appropriate for either preventing or in some cases treating a psychiatric behavioral issue, and that could be something like delusions, it could be paranoia, it could be hallucinations, it could be restlessness, we'll talk about some of the areas in a few minutes that medications don't work well for. But the underlying treatment, at least in patients that have 2 types of dementia, Alzheimer's disease and Lewy body dementia, are the cholinesterase inhibitors. And these medications are working to prevent the destruction that we naturally do to keep blood levels at a certain level in our brain of a neurotransmitter, a chemical that facilitates transmission of communications between neurons, called acetylcholine. So donepezil, Aricept, ribostigmine, Exelon, galantamine, isradipine. These are all in the same class of drugs called cholinesterase inhibitors. And there is good evidence that in Alzheimer's disease that these medications reduce the need for psychoactive drugs later on to manage behavioral problems. Doesn't mean that problems don't happen, but the studies have reflected that they do reduce the need for those medications. To somewhat degree, Namenda or memantine also, especially when it's added to one of these cholinesterase inhibitors, seems to have an additional benefit. What's not quite clear is how long that lasts. In some studies, it only lasted for about 6 months, and others question the value of Namenda or memantine. But I think it's a fairly common practice since these are the only medications we have to treat Alzheimer's disease, and we're going to use them, and I think most clinicians do, to maximum potential benefit. Now, having said that, Namenda or memantine and Lewy body dementia may make some behaviors worse, and it's my approach not to recommend that medication in Lewy body type dementia. And frontal temporal dementia medications like donepezil, Aricept, and Exelon, Razodine may make behavioral issues worse. So there's an example where in an Alzheimer's patient they're beneficial, even more so I think in Lewy body dementia, or they're not approved by the FDA. Your physicians can certainly prescribe them for that, and we almost always do. Rivastigmine or Exelon is approved in Parkinson's related dementia. But in fact, I think all of these medications are equally effective in Lewy body dementia and probably Parkinson's dementia also. So these are very useful drugs, even more so, more dramatic. For example, in Lewy body dementia, hallucinations that occur early in the disease, almost always visual, sometimes auditory, but usually visual, usually respond to one of these medications like Aricept. And so we don't use an antipsychotic for those kinds of conditions and those issues. So again, Namenda or memantine in the Lewy body patient may make behavioral issues worse. So that's an example where it's important to have some idea of what type of dementia, and usually you do. Usually the difference between Alzheimer's and Lewy body is fairly definitive. Not always, but most of the time. So it's my approach to optimize drug therapy in Alzheimer's disease to try to titrate to the maximum effective dose. I'll come to that in a minute because there's some new dosage forms out, at least one in particular for Aricept. Don't expect an immediate response. All three of these medications are balancing, if you will, or rebalancing neurotransmitters, chemicals in the brain, and it may take several weeks to see the full response. If memory improves in Alzheimer's patients, that's great. We don't always see that. And as I caution individuals when I give these lectures to healthcare providers, is don't think of these as memory drugs. What you often will see, though, is a reduction in apathy. People are more engaged in their environment. They're able to participate in activities to a greater degree. So these are all very positive, I think, outcomes that are often overlooked. So patient caregivers, again, this has to do with expectations. So discuss this with the prescribing doctor or nurse practitioner is what you can expect from these medications as far as a positive response. Monitor for adherence is important once these are started and titrated up that that dose be continued unless you run into a problematic side effect, and then that's important to communicate with your healthcare provider. But if they're suddenly stopped for a long period of time, usually more than several weeks, except for Exelon and I think Razodine, that is usually 3 days, then you have to retitrate back up to the dose that you were on before. So you can't just stop and start them. So I usually recommend at least a 6-month trial. One of the problems of assessing how well these medications are working is that the benefit may not be an improvement in symptoms, but a stabilization. In other words, the individual that's getting the medication that's diagnosed with Alzheimer's is not progressing downward at the same degree, and that's sometimes difficult to assess. And Lewy body dementia, usually the results are much faster, and usually you see a response within a week or so, and sometimes it's fairly, frankly, dramatic. But unfortunately, the disease progress is still advancing, so individuals will decline in both Alzheimer's and Lewy body over time. So in the Alzheimer's patient, after the dose has been titrated to Effective maximum dose, at least 10 milligrams, is tolerated. Consideration is to think about adding drugs like Namenda or Memantine. And I usually recommend tolerating to the maximum dose that's generally used, and I say that because now Aricept is available in a 23 milligram, and you should be on at least 10 milligrams. I think it's for at least 3 months before that is considered. But I found in my experience is that there are more problems with the 23 milligram. Sustained release should never be cut or crushed. See a lot more gastrointestinal problems, diarrhea, and syncopal or fainting episodes, and so on. So individuals with Lewy body dementia are much more sensitive to these adverse effects. So if we titrate those doses up higher in Lewy body patients, we do it very, very slowly. Avoiding anticholinergic drug interactions, and that's like your drugs like Elavil, for example, Benadryl, that's in many over-the-counter sleep medications, Flexeril, and a number of others. That's why it's not a bad idea with your pharmacist is to go over the list of medications that are being taken and look for ones that have significant anticholinergic drug interactions. And you can ask your pharmacist exactly that using those terms. He or she will understand it. So let's move on now into the patterns of behavioral disturbances. I have firsthand knowledge of this. I deal with these every day, sometimes multiple times a day, in-home settings, nursing home, assisted living, and so on down the line. So once we've completed some of the background that I've gone through in the last few minutes, then we can think about, so what is the goal of therapy? What are we treating? And sometimes it's mixed. Depression, agitation, and anxiety can all go together, for example, related to the depression, and also because of the dementia. Psychosis, I think, is less common, but more common in the Lewy body patient, and it can occur early on. Again, the cholinesterase type of inhibitors like your Aricept can actually be used to treat those hallucinations. By the way, very often early those hallucinations are not disturbing to the individual, and they can describe them in great detail. So depression is often a component, if not initially, later on with the dementia, which is understandable, so it's important to treat that. And I'll mention it now so I don't forget, is that in older adults, and I mean elderly, especially those over and get into the 70s, 75, depression and pain are the two undertreated areas I see of the many patients that I review during the course of a year. So while we sometimes and do use too many drugs in our older adults, in those two areas I find that often they're undertreated. So those are especially areas to watch out for. So what I suggest to you as caregivers out there, and frankly as healthcare providers, is to think of what are the symptoms of agitation. Is it physically non-aggressive? Is it just restlessness? Is it physically aggressive? Is it assaultive? Biting, scratching, hitting? It's a very different situation than someone that's verbally threatening it. Or is it just verbal, someone that is making continuous noises, repetitive noises, or disinhibition, sexual disinhibition, and others. But to keep a diary as to the type of agitation. So agitation, again, to me is a very general term, and I almost never recommend a drug just based on the word agitation. So I have a patient, Ron, that's very agitated. What's a good medication for that? And my first question is, what do you mean by agitation? So as a caregiver, it's very important to keep accurate information about the type of agitation, when it occurs, any of the circumstances. Is it feeding, bathing, toileting? Is it related to an activity? If there seems to be pain involved, and so on. But keeping a diary and being as specific as you can for your healthcare provider will really go a long ways, I think, in selecting the right medication, or in many instances, a non-drug treatment. So I think it's important to think of these as treatments. So sometimes our behavior as individuals that are interacting with someone with the dementia are a stimulus to the problem. Do not argue. I can't tell you how many times I've been in nursing homes, even in Alzheimer's care units in a locked unit at midnight, and have heard healthcare providers arguing with a patient who has a dementia. The healthcare provider never won that argument, at least in my experience. Diverting the person's attention, moving on to something else. Don't overstimulate. An example of this came up about a frontal temporal dementia patient that struck someone who he was waiting in line at a restaurant. And so you go, gee, that's too bad. That's not a good thing to happen. As it turned out, he didn't hit anyone. He put his hand on someone and tried to push them aside. Prior to that, his family had taken him Christmas shopping for 2 to 3 hours in various malls. So by the time he got to the restaurant, he was frazzled and he was on edge, and fortunately nothing really serious happened. So the treatment for this is educating the caregivers on living with someone that has this type of dementia. Monitor caffeine intake. Stimulants can always be a precursor to problems. Assess for pain or discomfort. Many times we find that just treating potential underlying pain removes or reduces the behavioral problem or issue. Assess medications that might cause confusion. Many medications can. For example, if the brain is sort of clouded with too many drugs, that can cause problems of confusion, which can lead to behavioral issues. And checking the environment. Something you probably heard is called sundowner syndrome, or sundowning. And actually sundowning is a collection of problems. It's not a simple problem in itself that is sad. I think it's not consistent to say you can just give a drug for that. You need to look at the problems and the components of the problems that are creating this behavior. And that's an area that I have some experience in, and actually have been in nursing homes as part of that assessment as an observer. So step 1, document and evaluate the behavior. Is the behavior precipitated by any event? Determine if the behavior poses a hazard. Many of these issues that I'm involved with in medications don't really require medication. Some of them do. Assess behavior for possible non-drug therapy. Is the behavior amenable to drug therapy? Wandering is not treated or shouldn't be treated with drug therapy. Wandering does not respond to drug therapy unless you literally sedate the person to the point that they can't move well, which is not a good idea. Pros and cons of drug therapy. All medications, of course, have potential side effects. Very important is to select the least hazardous drug. I'm afraid too often, and we're going to talk about drugs in a minute, specific drugs, that we reach for antipsychotics too soon, and drugs like Ativan or the Valium-like drugs too soon. And goals and monitoring parameters. Where are you going? How will you get there? How will you know when you've arrived? Most of the time, it's important, in fact, probably maybe all the time, to reevaluate the situation and evaluate, is the medication still needed for this particular behavior, and can we reduce it or titrate it off? So we've got a lot of drugs out here that have been used to treat and are used to treat behavioral issues in individuals with a dementia. None of the medications are approved by the FDA for treating behavioral issues related with the dementia. In the UK, Risperdal or risperidone is approved for treating behaviors that may be hazardous to an individual caregiver or to the patient, but not in this country. So antipsychotics have been misused, and we know that. Haldol, for example, has been around for a long time. Mellaril, which we thought back in the 60s, early 70s, was one of the safest drugs in an individual that has a dementia, we now know is one of the worst drugs, especially for the issue of possibly causing cardiac arrhythmias. So the second generation drugs are different in some respects. I'm not going to go through each and every one, but I'll touch on just a couple of comments about them. Risperdal has the best evidence in 3 large studies in treating patients who have Alzheimer's disease for a variety of behavioral issues. Usually the effective dose at the end of the study was 1 milligram. patients that got up to 2 milligrams had more Parkinsonism. It's one of the side effects of these medications. Less so with the Zyprexa, but also Zyprexa, or olanzapine is the generic name, has some other problems, a lot of weight gain. It can alter serum lipids like increased cholesterol, higher risk for falls, although all of them can cause falls. I think Zyprexa, especially in Parkinson's patients and Lewy body patients, is a special risk. And in fact, there's very little good evidence to support the use of Zyprexa in treating behavioral issues in Alzheimer's patients. Seroquel or quetiapine is, if you will, a more lower potency medication in this respect. Is more sedating, has mild anticholinergic activity, and usually has to be given multiple times a day, at least twice a day, unless the long-acting form is used. Abilify is a fairly new one that's been out for a while. There's a couple of studies that suggest it has some benefit at sort of medium-range doses in managing behavioral issues in Alzheimer's patients. It tends to have a side effect a little more common for it called akathisia, which is restlessness or increased activity. So in someone that has a dementia, that may present some problems in identifying where there's a side effect of the medication or it's caused by the behavior related to the dementia. And Geodon is, as far as I know, at least in my practices, we rarely use it. There's no really definitive studies in elderly patients with dementias. There are case reports, and has the possibility, at least a higher proclivity to increase something called the QTc interval, which can, if it gets high enough, increase the risk for cardiac arrhythmias. Newer ones like Latuda, Sapphiros, I believe, is another one. As far as I know, there are no studies using these medications to manage a behavior related to a dementia. And I usually believe it's important to go with what we know, so I tend to avoid suggesting medications that I can't identify evidence in the literature to support my decision. So antipsychotics have a role. I think by and large the role is in treating severe delusions that can't be managed in other ways. We'll talk about that in a minute. Hallucinations that are very disturbing or particularly disturbing to the individual and can't be managed in other ways, or there's no source found for them, and assaultive aggressive behavior. And again, these incidents may occur over a period of time, but everyone should be evaluated after being on these medications for a reasonable length of time, and the process of thought to reduce the dose, titrate off if possible. The side effects of tardive dyskinesia, which are serious with drugs like your older drugs, like your Haldol, are much less common with the newer ones, so they are safer in that respect. Like Risperdal, there are some case reports, a couple with Zyprexa, and one or two that I know of with Seroquel. All of these medications, though, increase the risk for mortality. To put it simply, they increase the risk for death. Usually strokes, sometimes heart attack. The older antipsychotics, also in elderly individuals with dementias, increase the risk for death. So it's not a huge increase. It's usually about 1 to 1.5% over the expected rate for having a stroke or heart attack when you get into this age group. But it certainly is there. It's a black box warning that says that, and it's important to discuss those issues with the healthcare providers. So we talked about the increased risk, the Parkinson's-like side effects, tardive dyskinesia, but much higher in the first generation, especially with drugs like Haldol, weight gain, diabetes. Actually, I didn't mention that, but that's an issue with olanzapine and also with Zyprexa as a brand name, and also Seroquel. All of them increase the risk for falls. So many, many drugs do that. A very useful group of drugs that's often overlooked are the antidepressants, especially those in the Prozac family. I usually don't select Prozac or Paxil for my elderly patients for two reasons. One, they have a lot of drug interactions, and sometimes those can be clinically significant. And the fact that Paxil or paroxetine does have anticholinergic, that type of drug that we don't like. And also when you discontinue Paxil, you have to be very careful because suddenly stopping it releases, it's called a withdrawal syndrome that can be agitation, anxiety, sweating, insomnia, and so on. Is very unpleasant to last for a few days. So we do use medications like Celexa, citalopram, usually as antidepressants. They're good for anxiety. They're also good for obsessive compulsive behavior, usually at higher doses than for depression. But more importantly, there's pretty decent evidence, 2 studies, Polak et al. Did a couple of them, of citalopram or Celexa is used to manage behavioral issues related to Alzheimer's disease. And so especially issues that involve impulsive behavior, even to some extent milder delusions. We have some experience with that in our clinics, and we do use these medications, usually citalopram, sometimes Lexapro, for managing mild to moderate behavioral issues. Bupropion is useful as an antidepressant, but not really for that type of behavior that I discussed using the Celexa types of drugs. So Wellbutrin is often now I find added to SSRI like your Celexa or your Lexapro in patients that haven't responded well but have responded to some degree in managing their depression. So mirtazapine or Remeron is useful not only small doses for sleep, increases weight gain. It's frankly a pretty good anti-nausea medication, but I find little evidence for its use in behavioral issues related to a dementia. The SNRIs or Effexor and Cymbalta can be useful for depression, but also useful for managing underlying pain issues, so sort of an adjunctive agent to other pain medications and chronic pain issues. Trazodone we usually reserve for sleep, not used much anymore as an antidepressant, but I think is a pretty decent sleep medication. And a brand new one, vortioxetine or Brintellix, is on the market as an antidepressant, just approved, and it has some interesting component that appears, quote, in quotes, appears to improve cognition, possibly memory, but that's not clear, in elderly patients. So that's because it affects some neurotransmitters, some neurochemicals that are in addition to the ones that it affects, which are more like the Prozac, Zoloft, Lexapro type of drugs. So we'll see if it has those benefits. It may be true. I hope it is. Don't rush right out and ask your provider to write a prescription for it, because for one thing, it's probably not covered by your health care insurance. And the last time I checked, a 1 month's supply of a beginning dose is about $340 US dollars. So we'll see. So it's always, I think, wise to wait a few weeks before you jump to a new medication. So antidepressant risk: falls, nausea, headaches, tremor, dry mouth with some, and importantly, sexual dysfunction, which is sometimes overlooked in older adults as an issue. Depakote is not a medication I recommend for behavior. It is used for treating bipolar disorders and prophylaxis for migraines. It's useful in a couple of other conditions too, but mostly in seizures. The evidence is lacking for its use in managing behaviors related to a dementia. And a study out of Arizona, I believe last year or the year before, a 3-year study, did not reflect any benefit in managing psychiatric behavioral issues, and those patients on Depakote, valproate, actually had more brain loss than those on the sugar pill. So don't stop any medication. Usually I say this at the end, but I'll say it now. Based on my comments, discuss them with your healthcare provider, because they may have other reasons for prescribing it that I'm not aware of. And ordinarily, it's not a good idea to stop any medication cold turkey. So one of the problems that I see in managing behavioral issues in the community is the overuse of drugs like Ativan. Ativan is in the Valium family. It's different than Valium in that it's a more potent benzodiazepine. So 1 milligram of Ativan is equal to 5 to 10 milligrams of Valium. So Ativan is a more potent drug in that respect. It is different in that it does not accumulate like Valium has active drugs, active metabolites that will accumulate in the body over time, especially in older adults. But Ativan is not short acting. Some practitioners believe that it is. Some believe it's safer in the elderly. It is absolutely not safer in the elderly. All these medications, but especially the more potent ones, can impair memory and can impair coordination skills. So there's some individuals, some research has been done, some of my colleagues in psychiatry have agreed with this clinically, that when drugs like Ativan are used, is that when it wears off, which is usually about 8 to 10 to 12 hours after the medication is given, there can be a spike in anxiety, and so it's sort of a rebound effect. Someone named Kales, K-A-L-E-S, has done some work in that some years ago. And clinically, some practitioners agree with that, but not everyone does. But in any event, my approach to these medications is small doses, much less than 1 milligram, 0.25, maximum of 0.5, unless you're using it prior to a procedure like an MRI or sometimes a dental procedure. Lewy body patients are much more sensitive to these drugs, and if they're not taking them currently, then you need to start at a very low dose. The medication is only used for a short duration of time, always with the plan that that medication is going to be discontinued, and if they've been on it for a few weeks or a month at least, then you'll want to taper that medication off because you can have some withdrawal symptoms. So these are medications that are useful. I think that they're probably overused in my estimation in the general community. They can impair memory, they do impair coordination skills, and I would say in all of my clinics that I work in, we work to use these medications as infrequently as possible. So I think I've touched on all of this, the confusion they can cause, additive with alcohol. I haven't mentioned that because alcohol is another medication that can cloud the consciousness. Our brains as older adults, and I'm an older adult so I can speak to this, is our brains are more sensitive to drugs like the Ativan kinds of drugs. And again, the drugs like Valium or diazepam will accumulate. So if you were taking diazepam for a month and you're 75 years old, it would be approximately another month before all that drug was out of your body. So I brought up a lot of issues. I hope giving you a few tips here. We'll take some questions, but I want to remind you again not to stop or alter the dose of any medication without first discussing it with your medical provider. If you need more drug information, start with your pharmacist. But here's a couple of good websites. rxlist.com is free, and I think it's an excellent source of objective drug information. Dr. Oz, in my opinion, is not, but he's interesting and I think entertaining. The Memory Clinic has an excellent website with a lot of instructional information and videos, some involving how to manage behavioral issues and quite a bit on drugs, as well as the Brain Health Center's website. So those are two websites that I would recommend to you. And I've got Alice in Wonderland there because I love a quote from Alice in Wonderland. And part of this is she says, you know, this morning I woke up and I knew exactly who I was or who I am, but now I'm not so sure. So I always like to keep that in mind. With that, let me open it up for questions.
Okay, thank you, Ron. You have a wealth of knowledge on this topic. We're really thankful that you took the time to share with us today. We have a few questions. Yeah, you're welcome. We have a few questions. We have some time to take a couple more if anyone wants to send some more in. But the first one I have is from a nurse that works at an adult day center. And she said she wants to know what medication is best for sundowning. She only knows of Ativan.
Well, that's a great question. And there's an easy answer to that. No medication is good for sundowning. None. There are medications that can be used depending on the components of the problem. So the key to sundowning is to break down the issues that are causing the behavior. And let me give you an example of a patient who I actually saw personally accompanying one of my physicians on a visit to a nursing home of someone who was diagnosed with sundowning. And the components were she was undertreated for pain, She was not treated with the correct pain medications. She was dosed too frequently with Ativan, which were clouding her consciousness. She had severe dementia of Alzheimer's type, so this is part of the problem. She was in an environment that in the evening was questionable because she was allowed to have TV, and when I visited her with my colleague, a war movie was on. I could hear it all the way down the hall. It was sundown, and light was flashing on the top of the ceilings as the drapes were swirling, created almost a psychedelic effect. She was partially conscious because, as one of the nurses said, she became very agitated, as she often does at this time of the day, and they had to give her an Ativan. When I looked at the medication administration record, she was getting Ativan generally 3 times a day. When that drug wears off about 2 or 3 in the morning, she's going to be agitated again. So we went through the medication history. We got her on different pain medications, one for neuropathic pain, which wasn't being treated, one for skeletal muscle pain. We got her off of a number of medications. She was constipated, or she hadn't had a bowel movement in 5 days. And so this is just, I could go on and on. This was not just a simple case of someone has the problem of sundowning. Ron, what's a good drug? You've got to back up and start to unravel this really sometimes very difficult knot of a dilemma.
That makes sense. Okay, we have another question here. At what point would it be useless to try using meds for Lewy body dementia, such as Aricept or Razidine?
That's a great question. In fact, I was at a national meeting just in Seattle about 2 months ago, and someone was presenting on Lewy body dementia and gave a case and it diagnosed this individual with early Lewy body dementia. And actually it was a little more than early. It started moving towards a more moderate phase when it came to the physician's attention. And so the question they threw to the audience was, would you treat with a drug like Aricept or Exelon or Razidine, or would you wait? And several practitioners said, wait. I said, you know, and I of course spoke up, that's absolutely wrong. You need to treat as soon as you're sure, and you usually are pretty sure of the diagnosis. These patients very early on will respond positively to drugs like Aricept. It's very different than in Alzheimer's disease. We almost never see that kind of really positive response, once in a while, but it's really pretty rare. But you want to capture the quality of life, and to me this makes sense, on the front end, not wait to further down the line. So I'm a big believer, and I think pretty much all my neurologists that I work with, and I probably work with maybe 50, maybe 20, 23, something like that, neurologists in my 2 clinics, would agree, is that it's important to, once you've established the diagnosis, is you want to get this person on a cholinesterase inhibitor. I hope that answers your question, because that's a great question. So it's certainly an example there that it's important to identify the type of dementia. Of course, you can't absolutely identify it until autopsy, but a good neurology clinic is about 93% accurate.
Okay, thank you, Ron. And here's another question. Is it safe to use antidepressants while also taking antipsychotics?
Good question. So we're always, I think my colleagues and I are very careful when you're mixing psychotherapeutic drugs. And so antidepressants will be used, I have to think about this for a minute, because there are certain situations that you may use an antipsychotic. For example, like Seroquel, usually is the one, sometimes Abilify, to boost the effect of an antidepressant. And this would be in a situation where someone has a very serious depression that hasn't responded well to a full therapeutic dose, and maybe at least one and maybe more antidepressants that have been tried. So it's usually not a common practice, but it is done in a couple of antipsychotics. I think Abilify is one, and Seroquel, quetiapine is a generic name, are approved by the FDA as adjunctive treatment in depression. Usually when I see that done, it's usually done by a psychiatrist.
Okay. And I have another one. Are there any adverse effects to adding memantine?
Annie, that's a good question. Memantine, or Namenda is the brand name, is when it looked at it, and I've actually chaired a couple safety committees of studies where we looked at memantine, and so we're following the side effects. And a medication that has very few side effects, and they're usually quite mild. However, as I mentioned, in Lewy body type dementia, it may make behavior worse in some patients. I personally have seen this in clinical practice. It's in the literature. In a study in patients with multiple sclerosis that was published, the study was stopped because memantine really worsened the condition of multiple sclerosis. So in that case, the side effects resulted in stopping the study. So those are the situations that I know of, and this really tends to be pretty unusual that memantine has side effects that are troubling, that are bothersome. It's interesting, memantine is a medication that goes back some years. In the 1960s, I don't know if they synthesized it, but Eli Lilly did one of the early studies in the United States with memantine. And I believe it was being studied for diabetic peripheral neuropathies, and it wasn't effective. And they dropped it, and it migrated to Europe and was used almost like a folk medicine, used for all kinds of variable conditions. And then someone decided that to try it in various types of dementias, and these were patients that had, quote, dementia, so they had different kinds. And it was effective in some patients. From that, it migrated to European pharmaceutical companies and eventually was approved, and then finally came to the United States. Memantine is a single agent, and this is my take on it, so not everyone may agree with this. Memantine in Alzheimer's disease as a single agent is not as effective as the Aricept, Exelon, Razidine type of drugs. Sometimes, though, usually for cardiac issues, individuals cannot tolerate the cholinesterase inhibitors, and so then memantine is all you have left. In mild Alzheimer's disease, it is not approved for that, and it is not shown to be effective. It's approved for moderate to severe, and even in those studies, the studies are positive, but they're not as positive as we would like. In other words, in some of the domains, some of the instruments used to test the drug was positive, but a number of others weren't. And I think of one study that was a fairly large study and was supported by the pharmaceutical company that makes memantine, was not positive at the end of the study. And this was in Alzheimer's patients. Now, the thought of adding it to the cholinesterase inhibitors, though, I think has greater support in the literature and clinically. But even then, there's some disagreement. But we don't have other agents to use, other drugs. And I don't think, unfortunately, we're going to get new ones in the next few years. It's just the way things are looking. So what we have is what we're going to have to go with. Now, in frontal temporal dementia, because memantine will protect some of the neuron structures that are damaged in frontal temporal dementia, the tau protein, it was thought that it would be effective there. And studies, I don't know if they've been published yet, but they've been completed. It was no better than the sugar pill. So we don't recommend, or I don't recommend it in frontal temporal dementia either at this point. And by the way, the SSRIs, like the Celexa I mentioned, are the medications that we use in trying to manage behaviors related to frontal temporal dementia, but a lot of those tend to be impulsive behavior. And we will use trazodone as a sleeping medication in those patients as well, which may, in some cases, help with the behavior during the day. There's a small study out of France that suggested that. So memantine is a medication that I think less effective in Alzheimer's patients, should not be used in general, in my opinion, in Lewy body patients, and unfortunately does not appear to have any benefit in frontotemporal dementia patients. That's a great question. Yeah, it comes up even among physicians when I do talks for medical groups. This is always a hot topic, and people vary in sort of their approach to it.
Okay.
I wish it did more. It looks like it should. In animal studies, it looks great. But unfortunately, we're not that animal.
Thank you, Ron. So we have time for a couple more. Do the drugs that are used for Alzheimer's actually work?
That's a question I get a lot. Do they actually work? And my answer to that is yes, they do work. They don't work as well as you would like or I would like, but they do work. And I say that because if you look again, as I mentioned earlier, in the response in a patient that has Alzheimer's disease, the most pronounced response usually is a reduction in apathy, and that's a positive response. Memory may or may not improve, but being more engaged in their environment, being able to assist more with with still some instruction, but in certain household chores, for example, obviously small ones, but reducing caregiver burden, caregiver time, that's obviously very important. So in those patients, again, it's a kind of medication. It's not what we would like, but it's what we've got. It's what we're going to have for a while. I think important areas are managing possible depression. Again, depression is very common in individuals that have a dementia, and treating that is very, very important. So I think in that respect, yes, they do work. As I said earlier, not as well as we would like. Now in Lewy body dementia, though, again, the Aricept kinds of drugs, usually the response early on is much more pronounced, much more positive. And so that's obviously very encouraging to individuals, the family. But again, we often do caution that in fact, we want this to last as long as possible, but unfortunately the disease process will continue to progress. So there is some evidence in Alzheimer's that using drugs like the Aricept kinds of drugs, again I use it just in the general term, Exelon, Razodine, the same, may reduce the time to nursing home placement. So there's some evidence for that. Arguably, it may or may not slow somewhat disease progression. Some people say, yes, there is some evidence. Others would disagree with that. So I think it's maximizing what we have. But I didn't mention it, but I will now. One of the most important treatments that we have in treating Parkinson's disease and Alzheimer's disease is cardiovascular exercise. So we know that exercise is good for what's good for the heart is good for the brain. And so that's very, very important. A lot of the non-drug approaches are very important, and I'm afraid we don't give enough emphasis on those sometimes. Certainly in vascular dementia, managing blood pressure, cholesterol, exercise, again, usually cardiovascular exercise is extremely important. So there are a lot of things that we can do to maybe slow the progression, at least minimize the progression of the disease. But a lot of things we can do as individuals as we grow older is to help to maintain our brain health, nutrition, and so on down the line. I'm not a big fan of a lot of nutritional supplements. I deal a lot with those, and I caution people to be careful what you put in your body. Products out of China, Southeastern Asia, I don't recommend at all because of the possibility of heavy metals, arsenic, lead, and mercury have been found. Sometimes real drugs are in there. They're not on the label. There's a number of incidents of this that are in the literature. So I'm much more leaning towards the good nutrition, exercise, and sort of back to Dr. Graham, who developed the Graham cracker many years ago, was nutrition, cold showers, and hard beds. I kind of eliminated the hard beds and the cold showers, though, but I stick with the nutrition.
Okay.
That's a long answer.
Thank you, Ron. That's about all the time we have for questions today. Thank you for everyone who has participated in today's webinar. Feel free to call Family Caregiver Alliance if you have any questions at 800 445-8106. And again, you'll receive a survey in your email that we would really like you to fill out to shape our future programs. So thank you to Ron for joining us today.
Thank you.
Thank you, and this webinar is now concluded.